All right, well, good evening, everyone. I wanted to welcome all of you to this year's Nebraska Oncology Society Evening Speaker Series. So pre-COVID, the Nebraska Oncology Society would meet pretty regularly to discuss different topics in oncology. And since the pandemic, we've been able to pivot to a mostly virtual setting. But today we're meeting in this hybrid setting to start kicking us off to meeting in person again. So we hope that you're able to see more of your colleagues. And this is our fifth and final topic of the year. And so we're hosting a survivorship topic. Here is our agenda for tonight's event. And I want to thank this evening's exhibitors. Thank you guys for being here, and encourage you all to visit their virtual booths as well if you're joining us virtually. So with this format, I just wanted to go over a few housekeeping items. For those of you joining us virtually, we are using Zoom, so you can find all your webinar controls by hovering over either the lower or upper section of the Zoom screen. You'll find your microphone, webcam, and chat box options, among other things. So please make sure that your microphones are muted throughout the meeting. If you need to ask questions, feel free to use the chat box, or we'll have a Q&A section at the end of the talk, and you'll be able to unmute yourselves at that point. If you're having technical difficulties, please close your browser and use the link to access the webinar once more. The presentation is being recorded and will be uploaded to our event website at a later date. We encourage the use of webcams if you're able to help us have a more face-to-face environment throughout this hybrid setting. I also wanted to remind you to use the virtual platform to visit our exhibitor booths. You can chat with the company representatives live. So feel free to take advantage of that opportunity and thank them for their support. We would not be able to carry out our mission of enhancing patient care through oncology research, education, and healthcare legislation without their support. One CME credit is available for this event. Complete our evaluation on our event homepage to get your certificate. The evaluation will be live at a later date on our event homepage. I now want to introduce our speaker, Dr. Emily Tonoresos. Dr. Tonoresos serves as the director of the Office of Cancer Survivorship, part of the Division of Cancer Control and Population Sciences at the National Cancer Institute. In this position, Dr. Tonoresos leads the NCI's efforts to address the challenges facing cancer survivors and their families, to prevent or mitigate adverse effects, and to improve the health and well-being of cancer survivors from the time of diagnosis through the remainder of their lives. Dr. Tonoresos came to the NCI from Memorial Sloan Kettering Cancer Center and the Weill Cornell Medical College, where she served as the director of the Adult Long-Term Follow-Up Program for survivors of childhood and young adult cancers. Her research, which has been funded by the National Cancer Institute, the American Cancer Society, and the American Institute of Cancer Research, and others, focuses on cardiometabolic consequences of cancer therapy, childhood and young adult cancer survivorship, diet and nutrition, and care coordination for this population. Dr. Tonoresos earned her medical degree from the University of Rochester School of Medicine and a Master of Public Health from Johns Hopkins Bloomberg School of Public Health. She completed her internal medicine residency and chief residency at Columbia University Center, as well as a general internal medicine fellowship at Johns Hopkins Hospital. Thank you for joining us today.
Thank you so much for having me. And I'm sorry, I'll try to keep my voice through this talk. I really appreciate the opportunity to speak with you guys. And I'm going to share a little bit about what I've been working on in the Office of Cancer Survivorship. And I also would like to hear from you all, if we have the opportunity, about the kinds of challenges that you've been experiencing among cancer survivors in your setting, and what we might do to try to promote some research on those areas. Okay, I just have to minimize a few things so I can, okay, great. So I like to go back a little bit in history to talk about the Office of Cancer Survivorship, because although we were founded in 1996, that at that point, the survivorship movement from an advocacy perspective was actually pretty old. And this is a paper that came out in 1985 from Fitzhugh Mullen, who was a physician who was also a cancer survivor. And he wrote, "Despite success on the treatment front, we have done very little in a concerted and well-planned fashion to investigate and address the problem of survivors." And it was just over 10 years later that President Clinton signed the Office of Cancer Survivorship into existence. And at the time, Richard Klausner, who was director of the NCI and is in the back of that picture, next to the window, he said that the office was being founded in recognition of the large number of individuals surviving cancer for long periods of time and their unique and poorly understood needs. And thankfully, since that time, we have only seen growth in the population of cancer survivors in the United States. We just got new numbers that estimate that there are over 18 million cancer survivors living in the United States, and that we're going to get to 26 million by 2040, which does not feel that far away. And what we see on this slide is actually demonstrating the aging of the cancer survivor population, which is to say that actually almost 2/3 of current cancer survivors are over the age of 65. And we started to talk about different kinds of cancer survivors. So of course, the NCI uses a definition of cancer survivor that says that a person is a cancer survivor from the time of diagnosis through the balance of life. And that is a definition that has been around since the start of the National Coalition for Cancer Survivorship and the advocacy movement many years prior to the Office of Cancer Survivorship. But what was done recently is an acknowledgement that there are many kinds of cancer survivors, and that people can be cancer survivors who are on treatment or off treatment, who are diagnosed with early stage cancer and progress to metastatic or advanced cancer, or maybe even people who were diagnosed with advanced cancer and are living for years as survivors living with cancer. And so we have been working with Angela Mariotto and others here at the NCI to try to get a handle on this growing population of cancer survivors who can be said to be living with cancer. So these are people, and these are numbers about women living with metastatic breast cancer, but these are people who are really not expected to ever be done with cancer treatment. And whether they go through periods of time when they are not actively receiving treatment, they may have the expectation that the cancer will require treatment again in the future, or maybe that the cancer will come back and they will eventually succumb to their cancer, but that they are living for long periods of time with cancer. And so we came up just earlier this year with these estimates for the number of people living with metastatic cancer in the United States. And what you see represented here are the 6 most common cancers, which are, of course, are bladder, breast, colorectal, lung, melanoma, and prostate. And then the numbers of people living with metastatic cancer across the top, which total over 600,000 people. And then whether their cancer is metastatic as a result of a recurrence or a de novo diagnosis of metastatic cancer. And what we did when we figured out these numbers is we also tried to estimate how long have these survivors been living with metastatic cancer. And as you move to the right on the slide, you get longer and longer, or more years since diagnosis. And what you see is that when you look, for example, at the melanoma population, you have people living with metastatic melanoma for 10 years or more. And in fact, in that population, about 28% of people with metastatic melanoma have been alive for 10 years or more with that diagnosis. So we're not talking about a short-term scenario. We are talking about people who are living for years with metastatic cancer. And when you start to think about what those people might be facing, they're facing things like their financial toxicity, work-related issues, side effects from treatment, subsequent or other malignancies that could show up in a person with metastatic cancer. And all of those things are survivorship. So saying that we have a population of people who are living with cancer and they have survivorship needs might have sounded sort of strange to people maybe 20 or 30 years ago, but now we recognize that this is a very large population and they need a lot of the same things that people with early stage cancer need. We looked in 2020 at the number of grants that were being funded on survivorship research among those living with advanced and metastatic cancer. This is all across the NIH, including NINR, which is funding a number of these grants. We only found 25 studies that were being actively funded. So when we say survivorship research, we mean managing side effects, detection of second malignancies, and care coordination, and all of the things related to healthcare delivery for this population. So it was a very small number of grants. And these are some examples of the types of projects that we saw. So acceptance and commitment therapy for fatigue in metastatic breast cancer. Of course, fatigue is one of the most prominent and prevalent symptoms in people living with metastatic cancer. Promoting resilience in stress management. This was a randomized controlled trial for adolescents and young adults with advanced cancer. Understanding treatment tolerability in older adults with cancer, and technology-supported physical activity intervention for metastatic breast cancer survivors. So these are some examples of the types of studies that are being funded. After we looked at what was funded in the current NIH portfolio, we had a meeting and it was virtual, as you see. We actually had, it was 2 days in length, and we had representatives who were researchers, who were people living with advanced cancer, who were providers caring for this population. And we all got together over the period of 2 days to talk about what are the issues that need to be addressed and what is not being addressed in the research. Following that meeting, we published this request for research to understand and address the survivorship needs of individuals living with advanced cancer. We had our first application date in September of this year, and there's another application date next year. And the purpose with this is to really say, not only do we want to stimulate research in survivorship needs for people living with advanced and metastatic cancer, but also this is a way that National Cancer Institute can really put their money where their mouth is. And we can say that this funding opportunity has dollars that are set aside that are going to be funding a number of studies in metastatic cancer survivorship. So it's really a way to for NCI to prioritize a research opportunity or a research need. And in this case, the fact that it was directed to metastatic survivorship, I think, is fantastic. I just wanted to mention 2 other funding opportunities because these are things that I'm trying to get people to apply to, and also to signal the importance of these issues from the perspective of the NCI. So this is a funding opportunity that's coming out shortly related to pragmatic trials. And the idea here is that a lot of research takes place in somewhat rarefied settings with highly selected populations. And at the end of the day, it can be very difficult to implement even evidence-based interventions among cancer survivors. And so the purpose of this notice of award, a funding opportunity, is to try to stimulate applications in pragmatic trials. And if you're interested in this type of research, we're going to be having a webinar soon, and there will be a full announcement up on our website as well. But I'm happy to talk more about what exactly is a pragmatic trial and the other questions around that. I also wanted to mention, many of you may have heard of the STAR Act, which was authorized in 2017. And we got from the STAR Act a number of things in the cancer survivorship setting related to childhood cancer. Some of what we saw were these 3 reports from AHRQ on issues that are facing survivors of childhood cancer. Number 1 is transitions, meaning a pediatric cancer survivor who has to transition to an adult model of care or adult providers. Care models that include primary care providers. And this 3rd one was on disparities and barriers to long-term follow-up care for childhood cancer survivors. And that third report set the stage for this notice of special interest that we put out earlier this year. And what this notice of special interest is intended to do is to bring in some applications related to disparities affecting healthcare utilization and health outcomes among childhood cancer survivors. So there's a small body of research on why childhood cancer survivors do not come back for long-term follow-up. And so these are identified issues like how far away was your treatment center, or does your provider know about survivorship care? But there really were no studies to try to address the larger kind of systemic barriers that might contribute to disparities. For example, does your organization where you were treated have a policy that keeps you from coming back for follow-up care, such as they only see survivors on some days of the week, or they only see survivors who had specific types of tumors? And so there are all these things that can play into why a survivor might not be showing up for survivorship care, even if they realize they need it, even if they live close enough to get there. And so that's the intention of this funding opportunity, is to try to get to some of those higher level barriers at the level of the organization or the system, or maybe even policy. There's also a funding opportunity, and I usually do get some questions on this one related to cannabis use during active cancer treatment. And one of the reasons I get questions on this funding opportunity is that people don't really think of supportive care interventions that happen for people on active treatment as survivorship research. But when I take us back to our definition of cancer survivor and the way that we think about cancer survivorship research, you can see that managing toxicities, including this idea of treatment tolerability, but managing side effects of treatment, whether they happen at the time of treatment, soon after treatment, whether they persist from treatment into survivorship, or whether they show up years later, that is all considered survivorship research. And so cannabis and investigating cannabis and cannabinoid use in people who've been treated for cancer certainly falls within what we consider survivorship research. I finally wanted to mention some resources. So obviously, the purpose of the Office of Cancer Survivorship being situated within the National Cancer Institute is to support research. But in order to fund and support research in cancer survivors, you have to be connected to people who are caring for cancer survivors and people who themselves are cancer survivors. So a lot of what we do in the office is to try to connect researchers to needs and identify gaps, either in the NCI funded portfolio or from the perspective of a survivor or a survivorship advocate. So there are a few different ways that we do that. So one is this online tool called the NIH Reporter. This is a way that anyone can go online and find out what is the National Institute of Health funding on a specific project. So you could go to Reporter and type in cancer survivorship fatigue, and you could see everything that NIH has funded. I'm not sure how far back it goes, at least 10 years. Everything NIH has funded in the last 10 years or more on cancer survivorship fatigue. And then that can help. It helps me. I go here every single day. It helps me figure out what's funded and what hasn't been funded. But it can also help researchers because you are able to identify gaps. So you can write in your application, there are no studies that are currently being funded on this topic, or there is one study and it is limited to cancer survivors in a specific health system or something along those lines. So it's an extremely useful tool for a lot of reasons. We also have in our division some information for people who are trying to build a career in cancer survivorship. And this is under the heading of new grantees, early stage RO1 investigators, investigator profile. And this is just one of the profiles, but you can go to this page and read about researchers and where they're getting their inspiration and how they are finding purpose in the work that they're doing. We also have on that page sample grant applications, and this is a tremendous resource when you're applying for a grant. These are recently successful, recently funded grants in cancer survivorship in these different categories. And you can go here and you can see, how does a successful grant describe the gaps in the research, the innovation, and all of those things that are required, and that really can make your application stand out from a peer review perspective. This is an incredible resource. It is really, really very useful. And what's wonderful is that these grants are here because funded investigators told us that we could put them here. So really, there is a huge supportive community of researchers who want other researchers to be successful in this field. It's amazing. I love working in I love working in survivorship. This is just one of the ways that we try to support each other, as investigators. I did also want to mention a couple of research resources that are supported by NCI. There are 4 different resources that come from the SEER registries: SEER Medicare, which you may have heard of, SEER Medicaid, and then SEER MHOS and SEER CAPS. And if you're thinking about some observational survivorship research that maybe could be done through the SEER registries, please contact me and I can help you figure out where maybe one of these surveys or supplemental um, data opportunities can help support your work. I also wanted to mention some things that we're doing individually as an office to support cancer survivors and survivorship research. And one of the things is that I realized even before I got here that survivorship research can be somewhat isolating. I think that there are many places where there might only be 1 or 2 people in the whole institution who are working in cancer survivorship. People can feel that they're not supported if they're at an institution or in a division that's focused on cancer treatment or even cancer screening. They may feel that their work is not valued in the same way. And I think this is true from what I've heard from among providers, but also among researchers. And as I started to try to figure out what could I do to help people have lifelong careers in survivorship research, I discovered that actually a lot of what affects us in survivorship also affects other scientists and other clinicians. So there is a hyper-competitive funding environment. In clinical care, of course, there's a hyper-competitive environment of reimbursement. There's an overall decline in real dollars available. There's an increase in the cost to conduct research. There has been expansion in the number of investigators and institutions. There has been unequal distribution of grant dollars, and this is one of the most discouraging things for early and middle stage investigators. Senior investigators who are later in their career tend to be successful and repeatedly successful. And so grant dollars are more likely to go to those senior investigators who are later in their careers. And really, we need a stable and diverse biomedical research workforce. I would add clinical workforce as well, in order to be successful in taking good care of cancer survivors. And so these are some very real challenges that NIH is facing and that I think are especially relevant to survivorship. Along those lines, and with those ideas in mind, we created a new series of short talks on creating a career in cancer survivorship. And so far, we've had 3 speakers. The first one was this amazing talk by Supriya Mohil, and she really talked about how during those difficult times in her career, she was able to draw on her inspiration and the support of her mentors in order to keep going in this field. And it's a terrific talk. It really, I think, has been useful for the junior faculty who participated in the talk and who watched it afterwards. But she's not the only one there. But this is one way that we're trying to support junior faculty and new investigators in the field. We're also expanding and growing our survivor and caregiver stories on the Office of Cancer Survivorship website. This is a place where, of course, clinicians and researchers can come and read stories of cancer survivor experiences, but also where survivors themselves, I think, can maybe look for some things that sound familiar. This page has been part of the Office of Cancer Survivorship website for many years, but we are adding to it. So if you've been to any of our meetings recently, you may have heard Bethany or Christine speak, and so their stories are here, and there are others as well. If you are a cancer survivor or you know a cancer survivor who you think might want to contribute in this way, that is also an option. So please reach out to me. We are growing as an office. We recently hired a deputy, Dr. Michelle Malika, and we also have some new staff coming on board this year as well. And lastly, I just wanted to mention a few upcoming talks that are part of the Office of Cancer Survivorship Director Series. We just had last month this amazing talk from Ron Epstein and Jill Feldman on prognostic information. This talk is now available on the website after being recorded last month. And what Dr. Epstein does, and he's really a skilled clinician and researcher who came from the general internal medicine / PAL care, supportive care world, but who, or I'm sorry, not general internal medicine, family medicine, I believe, but who has had so much to say that was really relevant to taking good care of cancer survivors. And Jill Feldman, who some of you might know, is a lung cancer advocate who was diagnosed with lung cancer, I believe around 10 years ago at this point, and has been on and off treatment for progression and recurrence at different times over those 10 years. And they both had a lot of very useful information and inspiration and advice on how to take good care of patients. And actually coming up in 2 weeks, we have Dr. Eli Diamond and Deanna Fournier, and they are going to talk about living with rare cancer, lessons from survivors and caregivers of histiocytic cancers. I keep messing up that word. Histiocytic cancers, such as histiocytosis, which is what I want to say when I see that word. And what this conversation is going to be about is actually a really interesting relationship between Dr. Diamond and the Histiocytosis Association in terms not just of research funding, but also kind of a two-way communication about the needs of the population, the participants in the research, and then how the research can actually make lives better for the people, the participants and their family members who have been part of the work that Dr. Diamond is doing. So it's a fascinating conversation and a really beautiful relationship that they've had as researcher and advocacy partners. And that is coming up in 2 weeks. And then in December, we're going to have blending survivorship with palliative care for people with advanced cancer in the precision oncology era. And Laura Petrillo, who's from Mass General, and Ann Charity Hudley, who's actually a cancer survivor and also Associate Dean of Educational Affairs at Stanford, are going to be talking about how, for several years now, we've been pushing the idea that cancer survivorship starts at the time of diagnosis, but we really have been hesitating on the second part of that definition, which says through the balance of life. We've really been hesitating on the whole end of life area topic. And I think that what Dr. Petrillo and others have been showing us is that there really should not be an artificial barrier in hospice or end-of-life care compared to survivorship care, because as we see, supportive care is moving earlier in the cancer treatment trajectory, and survivorship care is doing the same thing. So I really think this talk is kind of taking us to a new place with survivorship, which is to say we should stop hesitating on palliative care and really embrace the ways that we can support each other as researchers and as clinicians. So that is coming up in December. I hope you'll be there. Thank you.
All right, so we'll open it up for questions or comments. And
Can I just say one thing to the group? Hi, everybody. So about 2 years ago, soon after I started in this office, I did meet with some providers from Nebraska, and we were talking about the challenge of people who are on treatment, who show up in the emergency room, and maybe their treatment center is in Lincoln or Omaha, and they show up in a local community center needing care. And there's a lot of challenges of care coordination and even getting good information from the treatment team. And that is a challenge that I heard of actually first from the people in Nebraska, who I subsequently heard in a problem that I subsequently heard about in lots of other places, and that actually there is some very active work going on at NCI related to urgent care and emergency care for people with a diagnosis of cancer that came out of that meeting. But I don't know if any of you were actually, if it's any of the same providers, but thank you for your input.
we're open for questions. So if you, Dr. Kapoor, are you? Oh, sir, we can't hear you. Hold on.
What is the environment like in Nebraska for cannabis? Is it available to people being treated for cancer, or?
It's not. So as of now, the biggest proponents have been kind of grassroots efforts via ballot initiatives.
Okay.
So during let's see, what would that have been? And it is, but it's not. So it's that Delta, what is it? Delta something or other. But it can't have THC. Yes, it's limited by how much
Oh,
it can have. So I think across the there's been kind of that push for that Delta as a gateway into allowing cannabis. There's been 2 ballot initiatives, and both have failed. The last one failed on a technicality. Nebraska law only allows 1 issue per ballot initiative, and the last ballot initiative have I believe they counted up to 7 issues on 1 ballot, because it's really difficult to do cannabis and only have it be a 1 issue thing, because if you allow people to use it, there has to be a sales support system. You have to exempt
wow.
sellers, exempt buyers. And all those things were wrapped into that ballot initiative, and the judge finally threw it out and said, yes, it got the votes. Yes, it passed. However, it did not, because technically it wasn't a legal ballot initiative to start off with. So I think that the grassroots effort is there. And particularly when you see the comments, it's patients, it's people with neurological issues, with cancer. So I feel like that initiative is there.
So maybe it's coming.
Yeah. I think slowly, but yeah, Missouri, I think, just passed theirs. I really do think that as long as there's federal until the federal
Right.
government decides to do something about it, as well as greater access to research,
Yeah.
I think will be the game changer, probably.
Mm-hmm.
And Dr. Torres, how is DEI going into all these research opportunities that you've outlined for us?
Well, I mean, certainly it's been a number of years that, equity and inclusion is a priority of the NCI in general, and that is not going away by any means. So there are a number of specific opportunities that I didn't even mention related to rural rural disparities as well as social risks. And that's things like, what is the neighborhood like where you live? Do you have access to affordable food and affordable housing, things like that. And so there are a number right now of funding opportunities related to cancer survivorship in DEI, but honestly, it's a priority and it's going to be a priority for a long time, even without those individual questions. That's, some of what we were trying to get at with that childhood cancer NOS is related to those questions about what are the barriers that are sort of higher level. And in childhood cancer, I think it's very interesting to think about because children, for the most part, have access to health insurance. And so when you see differences that start to emerge, even at the time of diagnosis and treatment, many times it's because of those higher level challenges. For example, if you have a child who experiences a recurrence and now is considered high risk or has some other features that require them to go to a different center to get their care, then that is going to create challenges for the family and for follow-up. And so you have the children with the more serious tumors or the ones who have recurrence or high-risk tumors who end up having the highest barriers to survivorship care because of things that emerge at the time of treatment. So for me, it's very interesting to think about those kinds of problems. And there are some settings where those problems, those types of challenges emerge very quickly and remain problematic for the children, as they go into survivorship. And there was a paper last year where they looked at they used SEER registry data on childhood cancer to show that, of course, over the last 3 decades, we know that death related to childhood cancer has decreased, meaning children are successfully treated for their cancer, but deaths related to late occurring side effects have increased. So as treatment has gotten more successful, they have seen more children living into adulthood who then suffer from late occurring side effects of treatment, including, unfortunately, a lot of second malignancies that are fatal. And so when you look at the overall number of childhood cancer deaths, if you include late deaths as well as early deaths, the number has not gone down. It's the timing of the premature death and the cause of death that has changed over time. So we can see very clearly in that work that we really are not finished. That's my clinic population. That's a population that I'm very passionate about. It's tiny, teeny, tiny in the survivorship world, but one that I'm very passionate about because there's still so much premature mortality, even though treatment is so successful, for the most part, obviously not for every child. So every time we talk about cancer survivorship and the needs of people in survivorship, I think we have to take our lessons from the places where we've seen tremendous success in cancer treatment and just recognize that that does not mean that the work is finished. Getting rid of someone's tumor is obviously the most important thing. It's the only way you can start to worry about side effects from treatment. So you have to get rid of the cancer, or at least find a way to manage it for a period of time. But once you've figured out how to do that for most people with that diagnosis, then you can't just act like your work is done. That's my perspective. So, and that's, I think, what that original editorial from Fitzhugh Mullen says, and that was really how the office came to be.
Dr. Kapoor, I think I see yourself on there.
Can you hear me?
So sorry, Dr. Kapoor.
Can you hear me now?
Yes, there we go.
I disconnected, sorry, when they are both on, but here is thank you so much for the great talk. And this is an evolving area, and we oncologists are witnessing changes over the decades, that there was no palliative care, no hospice care, no survivorship. Now we are struggling with the transition between all these different specialties coming in. But first of all, the definition of survivor sometimes has been a matter of debate, and they have come up with different names and alivers or previvers or drivers, and then even there's a dyers one. But I really appreciate the attention to the survivorship. One of the question is that is there any particular insurance coverage or reimbursement coverage for people with the survivorship classification? And we are now in the molecular era of the cancer treatments. As you mentioned on your talk, that sometimes the palliative care or active care versus hospice care can be all transitioning to each other. And then with the survivorship, there's another question. We take it as a general term now, but with different cancers, colon cancer survivorship, leukemia survivorship, lung cancer, there are different effects of treatments that they suffer. For example, rectal cancer patients suffer when they even cured with the colostomies or radiation-related effects, and the other cancer survivors may be suffering from different things. So do you imagine that in the future there will be subspecialties of survivorship? Also, not to mention there's AYA, adult young adolescent survivorship. Would there be a follow-up for different cancer survivorships, or would there be reimbursement issues for them? And it is still, I think, relatively new, and I would just ask your perspective on these topics.
Wow, such great points. So first of all, I do think that we need to have research and guidelines informed by the research that are specific to different cancers, different cancer diagnoses and different cancer treatments, including, emerging therapies. And but the fact of the matter is, we're coming up on 26 million cancer survivors, in 2040. We're at 18 million now. So and we know that 2/3 of them are older adults. So those people, that's millions of people who cannot possibly be followed even by a generalist who's specialty trained in survivorship like myself. There just is not the workforce. We have to figure out how to support primary care providers who are taking care of cancer survivors. And it's only getting harder. And when we ask primary care providers, what are your strategies for caring for cancer survivors? It's really sort of discouraging. So primary care providers, when they get a cancer survivor in their office, if they're concerned about something and they think it might be related to the original diagnosis or treatment, they do things like call a friend who's an oncologist. Some places have electronic consults where you can consult an oncologist. So take, for example, you have a patient who is a cancer survivor and you found a lymph node. And you have to decide as a primary care provider, is this just a regular old lymph node the way that I would handle it in any other 52-year-old adult? Or is this something that I should take a different approach with? I should send them to an oncologist. I should send them for a biopsy, and what do I order when I send them for a biopsy? All those kinds of questions. And the way that they figure it out really depends on where they work and who they know. And it's not dependent on any sort of system that we can rely on for good quality, high quality care. So there are some active areas of research related to how to take better care of survivors in a primary care setting. There's some work being done in different places to try to figure out how to do a good job. But to me, I think that's the biggest problem facing us as a nation, as a field. How are we going to take care of 26 million people? We can't take care of 18. We can't take care of 8,
Yeah.
Okay, and the second question is on reimbursement. So, of course, we're not supposed to comment, as being government employees, we're not supposed to comment on legislation, but there is legislation that is, going through Congress to try to advocate or legislate or require reimbursement for survivorship care. And some of what we face as providers is the whole problem of the thinking specialties not being reimbursed in the same way as the procedural specialties. And so there aren't a whole lot of tasks in survivorship care that you can bill for the way that you can for procedure, for procedures. They're not really procedures. So that's, I think, a problem that we have as a nation, as a, how we've decided to pay for care in general. Affects survivorship care specifically because of the type of care that it is and what it requires us to do as providers. So that is a problem. There's multiple layers to that problem, but I think that is one of the problems that faces reimbursement for survivorship care, is the fact that it's not procedurally based for the most part. And there is a small amount of literature on places that are doing survivorship care and making it solvent. And the things that they are doing usually are utilizing APPs like nurse practitioners and physician's assistants, running programs that have a lot of the same types of people, so they get very used to dealing with certain types of issues. Those tend to work pretty well. And programs that are embedded in a health system. So there's a little more leeway. For example, if you're at a cancer center and you need a heart transplant, the patient is referred to some other academic medical center. And so your survivorship program does not get any sort of reimbursement type credit for the care that might be related to that transplant that person requires. If you're in a health system, you can make somewhat, you can be somewhat more umbrella in your discussions about reimbursement and contribution to solvency, because your specialists and the other types of procedures and testing and everything that survivor might need are still within your health system. So here, I live on Long Island, we have Northwell Health. That's a very large health system. And if you're going to a Northwell Health hospital, you're getting your mammogram in a Northwell Health facility, and you're also seeing a primary care provider who specializes in early breast cancer survivorship in the Northwell Health system, then that gives you a little bit more of an umbrella on the costs, and reimbursement related to caring for that person. But those are the places that seem to be successful. Yeah. That's what I would say.
Great. Thank you so much. Then one more last
Sure. Long answer.
Familiar with the American College of Surgeons? They approve the programs and they get accredited for College of COC, and they do have a standard that they have a survivorship that most community-based cancer programs, if they are approved by the COC, they have a survivorship standard that they have to meet. Where does that fall in terms of what your vision in the long run for the survivorship? Do you think that's a start there, or is it adequate, inadequate? Any comments on that?
Sure. Yes. So I did go to the American College of Surgeons meeting a month or two ago in San Diego to go to a session on the Commission on Cancer survivorship standard, because I think it is so important and it does play a very big role. I heard when they changed their standard that there were providers who lost their mandate to create survivorship care plans, and actually their time was being diverted. Their time that used to be dedicated to survivorship care was being diverted to other types of work. And so I talked very openly with Tim Mullett and the Commission on Cancer folks about, can we figure out how this standard can really be used to promote survivorship care and to not lose our providers who were being paid as a result of that initial mandate. And so it's very impactful what they do. I think that's what I've heard from providers. And I think what they expressed is that they felt that the survivorship care plan requirement was too narrow and too limiting, and that really what they want is for survivors to get good care. And hopefully that is more than just paying someone to comb through the medical record. You know, hopefully it's support services and you know, access to all different types of survivorship related resources. But I think it's still to be seen what's going to happen as a result of that standard that went, you know, that changed. I guess it was about 2 years ago now. Still to be seen, I think. But they're very interested in finding that out also. That was my perspective.
And I'm not sure how his copy has anything in that or not. My colleagues may know or comment too, but I think that to reduce it to the community level, which is majority of cancer patients are in the community setting,
Right.
rural or small towns, either College of Surgeons, and I'm not aware of the copy standards, be the best way, I guess, to bring it to the level of the community and the rural cancer care.
Yeah. You know, what's interesting is that I think there is just so much diversity, so much of a range in the types of places that are providing survivorship care, and that even to have the standard of the survivorship care plan was impacting different places very differently. So I think there's a lot of challenges there, but yeah, I agree with you. I think to have some clinical standard is a good thing. Some provision that says, you know, we should be finding ways to make resources available to cancer survivors. That's my perspective.
Great, and thank you so much. And just one last comment that I sent you an email about a project. I would hear back from you. And is this
Okay,
your
great.
email, right? Did you receive that or not? But
I'll take a look.
And I would love to your input on that too. And thank you so much for the wonderful
Sure.
talk.
Yeah, thank you.
All right, Dr. Torres, we have one question in the chat box. Thank you for your talk. Can you discuss more about what a pragmatic trial is?
Yes, I would love to. So the people in implementation science who specialize in pragmatic trials do not like to use the word real world. They do not like when we say real world, but really that is what pragmatic trials is. So the idea is if you have an intervention that has been shown to be successful in a certain setting, for example, the PRISM intervention, which is a stress management intervention, can you implement it or test it in a more real world setting? So that would be, can you test it with providers who are not specialists in psychosocial support care? Can you test it with actual patients and survivors who are being seen in a community setting? And what you do with the pragmatic trial is you put your outcomes on your process. So, for example, if you are able to demonstrate that people will sign up for your intervention, that's one of the ways that you can measure your success. So it's really about doing things outside of the highly restricted, rarefied air of the clinical trial, and trying to find ways to provide interventions in a real world setting.
All right. Do we have any other questions for Dr. Torres? All right. Seeing none, thank you so much for your time and for sharing your expertise with us today. Definitely appreciate it.
Thank you so much for having me. It's my pleasure.
So just a few announcements before we end the night. So the Nebraska Oncology Society is happy to announce that the San Antonio Breast Cancer Symposium will be held on Saturday, January 28th, here at this venue at the Marriott Regency, from 7 a.m. to 1 p.m. So we hope that you'll join us for that event as well. And with that, we've reached the end of our event. So I want to thank all of you for your participation, and I hope that you've enjoyed your time with us. I want to thank our speaker for sharing her time and expertise with us, as well as our wonderful exhibitors for joining us tonight. And I want to thank you all and hope that you all enjoy the rest of your evening.
Thank you.